Looking for the complete grand tour of the circulatory system? As you know, in your clinical charts and advanced textbooks, you will see us called the cardiovascular system. Cardio means heart and vascular means blood vessels. We are the ultimate 24/7 internal transport infrastructure of your entire body. Our system forms a continuous, closed-loop network of pipes spanning over 60,000 miles in an adult. In your clinical rotations, you will encounter us constantly through root words like angio, vessels, hemato, blood, or cardio, heart. Our primary mission is simple yet vital. We keep blood continuously moving so that oxygen, nutrients, and hormones can be delivered to every single living cell, while shifting carbon dioxide and cellular waste away to your organs of elimination. We are the system that keeps the spark of life flowing. The three core components. To pass your cardiovascular nursing exams, you must look at us as a three-part team: the pump, the fluid, and the pipes. 1. The pump, Mr. Heart, a hollow muscular organ about the size of your fist, sitting right in the center of your chest cavity inside the mediastinum. It acts as the double-sided engine that generates the pressure needed to shove blood through the entire body. 2. The fluid, the blood, the life-giving river carrying Ruby the red blood cell, oxygen transport, Ned the neutrophil, immune defense, and Penny the platelet, clotting patchwork, all floating inside a straw-colored liquid matrix called plasma. 3. The pipes, the blood vessels. Our pipeline infrastructure is split into three highly distinct types of blood vessels based on the direction they carry blood and the pressure they hold. Arteries, the high-pressure delivery. These thick, muscular, elastic pipes carry blood away from the heart. Remember, artery equals away. Because they receive blood directly from the forceful contractions of the heart, they hold incredibly high pressure. Capillaries, the exchange zones. Microscopic single-cell thin vessels that weave through your tissues to form a dense mesh. Their walls are so thin that oxygen and nutrients can easily slip out into the tissues while carbon dioxide slips inside. Veins, the low-pressure return. Thin-walled, stretchy pipes that carry deoxygenated blood back toward the heart. They operate under very low pressure and contain one-way valves to prevent gravity from pulling blood backward. The grand loops, pulmonary versus systemic circulation. This is a top-tier favorite for your proctored nursing blueprints. The heart functions as a double pump, managing two completely separate, continuous loops of travel simultaneously. 1. The pulmonary circuit, the oxygen recharge loop, the path, driven by the right side of the heart. The goal: the right ventricle pumps dark, deoxygenated blood out through the pulmonary artery straight to the lungs. The action: as the blood glides across the lung alveoli, it dumps out toxic carbon dioxide waste and sucks in a fresh load of oxygen. This bright red, oxygenated blood then travels back through the pulmonary veins into the left side of the heart. 2. The systemic circuit, the body delivery loop, the path, driven by the muscular left side of the heart. The goal: the left ventricle pumps that freshly oxygenated blood out through the body's largest artery, the aorta, sending it spraying upward to the brain and downward to the rest of the internal organs and limbs. The action: the blood delivers its oxygen payload to the tissues via capillaries, turns dark and deoxygenated, and returns through the vena cava back into the right side of the heart to repeat the cycle forever. Image demonstrating the dual loops of circulation, pulmonary circuit to the lungs and systemic circuit to the body tissues, the cardiac cycle and blood pressure dynamics. Every single heartbeat represents a perfectly timed, alternating cycle of contraction and relaxation that creates your patient's blood pressure. Systole, the squeeze phase. This is when the heart's ventricles contract violently, snapping the internal valves shut and slamming blood out into the arteries. Exam link. This generates the top number of your patient's blood pressure, the systolic pressure, representing the peak force exerted against the arterial walls during a contraction. Diastole, the rest phase. This is when the ventricles relax and expand, allowing blood from the atria to rapidly fill the empty chambers. Exam link. This generates the bottom number of your patient's blood pressure, the diastolic pressure, representing the resting pressure remaining inside the arteries when the heart is completely at peace between beats. Common circulatory diseases and pathologies. When pipes clog, pumps weaken, or pressures scale too high, systemic tissue starvation surfaces rapidly. 1. Hypertension, the silent killer. A chronic elevation of systemic blood pressure where the systolic pressure sits consistently above 130 millimeters of mercury or the diastolic stays above 80 millimeters of mercury. The pathophysiology. Due to aging, genetics, or plaque buildup, the walls of the arteries lose their elasticity and become stiff and narrow. The heart is forced to work twice as hard to pump blood against this intense resistance. The risk. Over time, this constant high-pressure pounding stretches and damages the delicate lining of the blood vessels, putting the patient at an extreme risk for a stroke in the brain, kidney failure, or a heart attack. 2. Atherosclerosis, the plaque clog. A progressive disease where excess circulating low-density cholesterol, LDL, slips underneath the damaged lining of the arteries. What happens? Max the macrophage arrives to eat the fat, gets bloated, and dies, forming a hard, calcified fatty ridge called an atherosclerotic plaque. This narrows the internal pipe diameter, restricting blood flow downstream. If a plaque ruptures, Penny the platelet will rush over and form an instant clot, completely occluding the vessel. If this happens in the coronary arteries feeding the heart muscle, it causes a myocardial infarction, heart attack. If it happens in the brain, it causes an ischemic stroke. 3. Chronic venous insufficiency, varicose veins. While arteries rely on high pressure, veins rely on the squeezing action of surrounding leg muscles to push blood upward against gravity. The crisis. If a patient stands for prolonged periods, or as they age, the tiny one-way valves inside the leg veins stretch out and fail to snap shut completely. The result? Gravity wins. Blood pulls backward down the legs, causing the veins to stretch, distend, and become twisted, resulting in painful swollen legs, varicose veins, and a high risk for venous stasis, ulcers near the ankles. Critical nursing assessments and interventions. The mapping of peripheral pulses. During every head-to-toe clinical assessment, you must physically palpate your patient's peripheral pulses to verify the adequacy of systemic arterial blood flow. Always grade the strength of the pulse on a standard 0 to 3 plus scale. 0 absent, emergency, no blood flow is reaching the limb. 1 plus, weak, thready, easily obliterated with light finger pressure. 2 plus, normal, healthy, easily palpable pulse. 3 plus, bounding, hyperdynamic pulse, often seen in fluid overload. The capillary refill assessment, to instantly measure microvascular perfusion at the bedside, firmly press down on your patient's fingernail bed or toe until it blanches white, then suddenly release. The target, the blood should flash back into the tissue, turning it pink again in less than 2 seconds. If a capillary refill takes longer than 2 seconds, it is a major nursing alert that the patient's circulatory system is failing due to dehydration, peripheral vascular disease, or early hypovolemic shock. The anti-embolism protocol, DVT prevention. When an adult patient is placed on prolonged bed rest following surgery, their leg muscle pumps stop working. Blood stagnates inside the deep veins of their calves, putting them at an extreme risk for developing a deep vein thrombosis, DVT, a massive clot in the venous system. Nursing action. Proactively implement DVT prevention protocols. Ensure your patient is wearing prescribed sequential compression devices, SCDs, or anti-embolism stockings, TED hose, to mechanically squeeze the calves, and administer ordered prophylactic anticoagulants like heparin or Lovenox. The ultimate danger: never massage the calves of a patient with a suspected DVT. Doing so can break the clot loose, turning it into a traveling embolus that will fly up the vena cava through the right side of the heart and wedge deep inside the lungs, causing a fatal pulmonary embolism, PE. Always document your patient's respiratory status and calf symmetry. Follow us on YouTube, Felix K's Explore for More. Otherwise, like, share, and follow us if you enjoyed the class. Thank you for your support.